we're going to introduce you to a panel of people, all physicians, who have been on, as we say in surgery, the other side of the ether screen. They've been on the other side of the doctor-patient relationship. They too have been patients who all suffered potentially life-threatening illnesses. Our moderator, I've got to be careful because I've got a couple of my bosses up here, so I got to be on my best behavior. Our moderator is Dr. Jerry, or Gregory Jerkovich, and Jerry's a professor of surgery at the University of Washington. He's the chief of our trauma service at Harborview, which in fact is the 5th busiest trauma service in the United States of America. He manages the administration of that, and in fact Harborview's Trauma Center is the only level 1 trauma center, which means just like Denny's, we're open all night. We've got a whole crew in the operating room, the intensive care unit, and a whole spectrum of specialists to take care of the critically ill and injured that are staffed throughout the whole night. Jerry received his medical degree in his home state of Minnesota. He completed his residency in general surgery at the University of Colorado and was a fellow at Duke University. He's board certified in surgery and surgical critical care. And he just ended his year-long tenure as president of probably the most prestigious trauma organization in the whole world, which is the American Association for the Surgery for Trauma. It's got 1,000 members, and it spans not just through America, both Canada and the United States, but really 30 other nations. His research interests include all those things you see there: injury prevention, hypothermia, outcome studies, alcohol and nutritional support in trauma. Major injuries really zap a lot of nutritional resources from a person's body, and the metabolic effects are wide-ranging, and Jerry is a world's expert in that field. He also has published innumerable articles, textbooks on treatment of trauma, and when he's not there with his nose down in a wound or speaking at an engagement somewhere around the world, we can usually find him casting his fly rod out there on the Yakima River in the Yakima Canyon. He loves to fly fish, and he loves to snow ski. So we're really pleased to have Jerry moderate this distinguished panel, which includes the following faculty members. Kim Anderson is an assistant professor of pathology here at the University of Washington. She's the director, ironically, of the breast pathology unit here at the University of Washington Medical Center, and she's an acting instructor in anatomic pathology. Wendell Patrick Fleet, aka Fleet at Harborview, is a mentor and teacher to generations of physicians and a revered clinician. Fleet takes care of the sickest of the sick, the poorest of the poor, and is really a role model for myself and many of my colleagues at Harborview. He's a nephrologist, and I don't know if you know much about nephrologists, but these are internists with an intense masochistic streak. They really like trouble, but unlike surgeons, they don't like to put sharp instruments in their hands. Next is Ben Greer. Ben Greer is a professor in the Department of Obstetrics and Gynecology here at the University of Washington Medical Center. He's the director of our Seattle Cancer Care Network and the Division of Gynecologic Oncology there. Carlos Pellegrini is our distinguished Henry Harkins Professor and Chairman of the Department of Surgery here at the University of Washington, and he's clinical practice here at the University of Washington and an international expert in what we call foregut surgery, or surgery on the esophagus and upper gastrointestinal tract. He's the president of innumerable different international and national surgical societies, and is a co-director here locally for our Center for Video Endoscopic Surgery. This minimally invasive surgery that is done via telescopes and long-handled instruments through tiny holes instead of giant holes like we make in people at Harborview. He's also the co-director of the Swallowing Center, a diagnostic center that studies patients with a variety of different difficulties in swallowing, like gastroesophageal reflux and the surgery therefore. Mike Ryan is an associate professor of medicine and the section head of the Division of Nephrology at Harborview. Really an incredible job. He's also a recipient of the UW School of Medicine's graduating class as a Distinguished Clinical Teacher of the Year, and gave the graduation commencement address in 2006. The director of the nephrology course for our second-year students, and really a superb gentleman and clinician. And without further ado, I want to go ahead and introduce Dr. Jerkovich and have him give his introductory remarks, and then call our panel up to the stools in front. Jerry?
Thanks, you. I have a distinguished panel that's going to be sitting up here, and I want to share with you that there are, I want you to think about this panel, 3 cases of lymphoma, 1 pancreatic cancer, 1 breast cancer, and 1 intra-abdominal sepsis and bladder cancer. Now, these are all physicians within the UW system. They're all physicians who have been patients within the UW system. They all have their own perspective on medical care, not just within the University of Washington, but medical care in general. So they have what I would term the inside-out perspective. So I want you to develop some questions for them. And I'll have them come up there, and we'll field with them some questions about their perceptions of healthcare. But to begin with this, I think it's important. My colleagues have done a nice job, I think, of bashing doctors and how poor they are communicating. But really, you have a responsibility as well as patients. So I'm going to present to you your 10 code of ethics responsibilities for being patients. So these are what things that you have to do. Let's begin with these. Number 1, do not expect your doctor to share in your discomfort. A doctor's involvement with your suffering may cause us to lose our scientific objectivity, and you don't want that. So it can't be involved with your discomfort. Secondly, you have to be cheerful at all times. You don't want a depressed doctor taking care of you, right? You've got to be cheerful for at all times. A doctor needs some of your reassurance. And really, how embarrassing to be suffering from not the disease that you're given. If you're given a disease, have the common courtesy to suffer from that disease, for crying out loud. You're going to make us look bad. Now, if the treatment isn't bringing relief, do not complain about that. Just accept the fact that you maybe have something else, but not the first thing is wrong. Now, this one, of course, is self-evident. Never ask them to explain what they are doing. It's presumptuous, really, on your part, that these profound matters could even be communicated with you, despite what you heard in the initial part. 5 more to go here. Now, you must submit to novel treatments and experimental treatments just in every sense of agreement. How else are we going to get famous and publish papers, unless you agree to do that? What is that, number 2 compared to that small school in the West? We want to be number 1, so you have to submit to more novel therapies. This one, well, of course, pay your bills promptly and willingly. That's just, need I say more about that? And this one goes along with it, really. I mean, if you're going to have a disease, really, I mean, have one you can afford to pay for. That's just not going to work out otherwise. Now, this one, very difficult. The doctor-patient relationship certainly is a privileged one, and you have a sacred duty to protect us from exposure to fallacies and shortcomings. So you got to keep that one under your hat. And lastly, oh my God, this is bad form. Never die. Now, this is very inconvenient and embarrassing. So really try to stay away from that part as well. So my colleagues before have set the stage for what doctors are supposed to do. Now you know what you're supposed to do. So I'm going to break from that and do a little bit about my story, because I'm one of these 6 physicians who have fallen into this pathway as well. My story begins with this. Actually, it ends with this. And this is a chest x-ray of the chest, and this right here is a huge tumor in the upper mediastinum. This is a tumor that's compressing the superior vena cava, that main blood vessel that comes from your brain down into your heart. And as this vena cava gets compressed, it blocks off blood flow to your brain, and it can make you stupid. And it can make you get a list of 10 things of how patients should behave in front of their doctor if this goes on long enough. My story begins when I was bending over one day to adjust a sprinkler head in the lawn, and I passed out with a shower of lights and sprockets, and I thought, well, my pants were too tight, or it's hot, or I shouldn't have had that beer. About a month went by, and then I was going on a jogging, a little outing with a bunch of surgery residents at a scientific meeting, and I just couldn't keep up, and that was embarrassing enough. But it wasn't that I was exhausted or that I hurt. I just couldn't do it. I couldn't get enough air. And finally, when I went on a long planned vacation with my family, was propped up on 3 pillows. I thought I had nasal congestion. My nose was stuffed all the time. I just couldn't sleep. And I was blowing up the air mattress of one of my kids, and I passed out again on the vacation. Said, well, really, I really can't have a beer now. This really does it. Now, you would have think that a physician by now would have figured out that something's wrong, but no. Another few weeks went by. This time I traveled to Minneapolis, my home state, as Hugh said, and went to a wedding of a good friend of mine, and there I was in the hotel room with my wife getting dressed for the wedding, and my top button couldn't button on my shirt. My neck was so swollen I couldn't button it. And I started muttering and saying, you know, now what? You're fat and your shirt doesn't fit. You're going to look like a dweeb with this big collar on there and the neck all tied up. And then it dawned on me just like that. I knew exactly what I had right then. Well, like any good surgeon, I did not go to the hospital. I did not fly directly home. I went to the State Fair in Minnesota and spent 2 days there, went to the wedding, and finally flew back, went right from the airport to the hospital, got this x-ray. If you notice, there's no label on here. This is what we call a stealth x-ray. Totally done by, talk to the radiologist. Can you take I did not feeling well. Can you do a chest x-ray of me, take this picture? No label, no time, no stamp, no nothing on it. I knew what it was when I came out, and I asked the radiology resident to interpret it for me, and he was too hesitant to say anything, but I knew exactly what I had at that time. So those were my signs, and those are my stories. Now, each of these other panelists, I'd like you all to come up to the table up here, or to those chairs, have a similar story. And I will ask them some questions to get us started. Anywhere you want, just ladies, gentlemen, take a seat. I'll ask them some general questions to get started with this, because this really is sort of a view from the inside out. And perhaps when I get them to answer, they might share a little bit. Start with Pat, my buddy Pat Fleet here, another Harborview patient. Pat's a nephrologist. Pat's got the chemo hair, aren't you, Pat?
Big hint.
A big hint. Big hint that you got the chemo hair. Pat, tell us a little bit about yourself, and then I want you to tell us what you think is their best memorable experience of being a patient, your most positive experience of being a patient.
I didn't have many positive experiences. I can tell you the worst experience.
Good, go with that one, the worst.
And that's the decrepitude. And you never know whether the decrepitude is your old age, your disease, or the treatment. But it is truly humbling. And organized medicine, as yet, doesn't take that sort of debilitating sort of trajectory into calculations about who's going to get better and who's going to get functional and who's going to go back to leading productive, useful lives. That was the hardest part for me. There were minor league glitches about bad food and stuff like that, but those were all surmountable. And my story is confusing. 6 years ago, I cut my thumb on a table saw. I feared flesh-eating bacteria after it got a little red, and took some antibiotics that one of my patients who died didn't need anymore. And then got a rash, and then got a cough, and then got some joint effusions, and then developed pleural effusions and pericardial effusions, and had truly a multi-system collapse that was unsolvable for 6 to 8 months. I was on close follow-up, getting x-rays, tests, whatever. And then whatever it was that I had exploded into a large B-cell lymphoma, for which I was treated and made a recovery, and then wasn't at all inconvenienced by any of that. I wasn't sick. I didn't take any time off work. Our rotation was such that every 3 weeks I'd see patients. I would get some chemo, have no white cells, and be doing other things, and then be back in time. Wasn't in the hospital, so really had no negative experience. But then about 6 months ago, I blew up again with some sort of accelerated catabolic phase in which I had no white cells, no platelets, no red blood cells. Spent a couple of weeks in the hospital with presumed sepsis. and then was truly a patient and truly ill and truly confronted maybe not surviving this thing. So two totally different experiences.
At two different times.
At two different times, and I'm adjusting to one and have erased the other, and don't have the kind of observations. I'm a poor witness to my own reality. I always have been. So I'm really not, I think I was in denial the first time around, but the second time I really had to accept my limitations and my.
Do you think, Pat, do you think because of your position, that because of who you were, that you got special treatment that the rest of this audience is not going to see when they become a patient?
I don't think so. I wasn't aware of it, we'll put it that way. There was certainly no attempt to bring me better tasting food from the
Now next to Dr. Fleet, sort of surprisingly, Dr. Ryan is also a nephrologist, and the three of us all work at Harborview, and the three of us essentially have all had similar forms of the same lymphocytic lymph-borne tumor. It's not that it's Harborview, maybe it's our age, maybe it's the fact that it is the fastest growing tumor population in America, 7th, moving up to 6th most common. But Mike, comment on the question, any positive experiences from being sick?
Yeah, positive experiences. I think for me, what it did for me is it did change my perspective about taking care of patients with kidney disease, interestingly enough. Pat and I work together at Harborview. My office is next door to his. And we see people with kidney disease, and they develop symptoms due to the buildup of poisons in their body. And it's tough to have kidney disease. And one day after I was getting chemo, I came home and I was sitting down in the car and I looked at the stairs going up to my house and I thought, can I make it up the stairs? And I couldn't think of anything I wanted to eat, and I didn't feel good, and every bone in my body hurt, and I wasn't thinking very clearly. And then all of a sudden I went, oh, Steve, which is one of my patients, and I knew exactly how he felt. And it really, really was enlightening for me to notice that.
Has it changed the way you practice medicine?
I think it has in a couple ways. I think for me, what Pat mentioned was important for me too, decrepitude. Physically, I did better than I thought I would, but thinking-wise, I just had no short-term memory. It was like I had Alzheimer's, so I took myself out of the patient care realm because I just couldn't concentrate. And I couldn't remember anything. All my friends would be correcting me and reminding me that I'd said the same story 3 times today already. So I couldn't think, and all of a sudden, I just thought, well, if I'm not a physician, then who am I? You know, I couldn't do what I do all the time. I couldn't teach, I couldn't take care of patients, I couldn't do the stuff I do. So now I have a different appreciation for being there and seeing patients, and it feels like a privilege to me to be able to do that.
One of the most interesting, I think, stories is next on the line, Dr. Benjamin Greer. This is sort of a family story and sort of a self-inflicted story that I hope he shares a little bit with you. And then I want to ask him some of these questions as well. Ben, you mind sharing with the audience?
No, I'd be happy to. My story starts actually when I was a freshman in medical school and got a call from my father that he had pancreatic cancer, and he died 3 months to the day after his diagnosis. It was the day after I had finished my last exam my freshman year in medical school. And so I'd always been concerned about, you know, would I be at risk for pancreatic cancer, and was doing my colon screening and talking to my gastroenterologist about, you know, was I at risk, and he said no. Only one family member, so that's not a big issue. And so I was kind of, was in the summer of 2002, I got a call from my older brother, and he said, oh, by the way, I just wanted to let you know I have pancreatic cancer. And I thought, okay, I guess I better call my gastroenterologist back, which I did. And with that, they went into kind of hyper gear about what, you know, what should be done. And so I serendipitously and very fortunately was here at the University of Washington, where they had a very active screening program for pancreatic cancer families. I had an endoscopy, ultrasound of my pancreas with a biopsy, and ERCP, where they squirt dye up your pancreatic duct, and had a conference with the surgeon and my Terry Brentnall, who actually will speak to you guys in a couple weeks about family things, and she's the pancreatic family person here, and my family who is here with me today. And the decision was that I should at least undergo an exploratory laparotomy, possibly a Whipple, which is where you only take out part of the pancreas, and possibly a total pancreatectomy. And I was thinking about what I should do, and I was trying to figure out, well, if I'm going to do this, I think that's important. I've seen several friends die of pancreatic cancer. It's not a very pretty picture. And I was faced with a national presentation in February of '03, and I was trying to decide, do I want to wait? And then I said, no, I can't wait. If I end up having an invasive process, I'll be upset with myself about that. So we went ahead, and it turned out that I had what's called pancreatic intraepithelial, which is a field effect. In other words, the entire pancreas was affected by it. And I had high grade in about a third of my pancreas, and grade 1 and 2 in the other part. So I ended up with a total pancreatectomy. The interesting thing was, I asked my surgeon how long I'd be in the hospital. He said, I could be in 17 days. And I said, no, I'll be out in 5. Well, he made it so I couldn't get out. I got out in 7. But, and I always told him it's always attitude. And so I'm happy to be a volunteer diabetic, and I'm happy to be vertical, and happy to be able to watch my son, who's here, grow up. So that's my story.
You seem a perfect one to ask this question. Seems that this is really a risk-benefit discussion that you would have to have. So, I mean, do you feel comfortable with that discussion of what's the advantages, what's the disadvantages? How did you have that discussion with your doctor?
Well, we had essentially a family conference, which had the genetics, Terry Brentnall, who's a gastroenterologist there, surgeon, the GI guy who did my ultrasound, and my family, and we had a very open discussion. And I think in my case it was, gee, if you don't have it, you could get a pancreatic cancer and be dead. And with the final pathology, that was a possibility. I have counseled a general surgeon from that little school in the East who had a known PIN on a laparoscopic thing, and he wanted to know, could you work 100%? So he happened to be out here visiting his brother, who was a dean on Upper Campus. And Terry called me up and said, would I talk to him? I said, sure, send him down to the clinic. I'm in clinic today. And it turned out my surgeon was down there also. And we had a conversation. And my final thing to him was, do you have young kids? Because he didn't want to have it because he didn't think it'd work. I said, I work 100% plus every day. I said, if you have young kids, if you want to watch them grow up, you should do it.
Yeah.
And he subsequently has had a surgery.
Okay, thank you. Well, next we have Kimberly Ellison, the cruelest of fates, of course, a breast cancer pathologist suffering unexpectedly at a young age from breast cancer. Kim, thanks for joining us.
Yeah, it was a surreal experience. I think it was beginning of March '08 when I took on the role of being director of the breast pathology service, which basically entails I'm diagnosing breast cancer. And 3 weeks later, I noticed sort of a firmer area in my breast, and I was breastfeeding at the time. I had a 7-month-old and a 4-year-old. And I thought, that's probably nothing. I'm only 33. I have no family history. This is what I do for a living. I'm just being, nervous because I see it every day. But my husband encouraged me to go, see my physician, and they encouraged me to go get some imaging. And I had a mammogram, and of course, if you're breastfeeding, it's just white. So, it doesn't help at all. Then I got sent to some ultrasound studies, and yeah, there was something there that was funny, but, again, I was breastfeeding. I didn't have risk factors. Did I really want a biopsy? And I'm a pathologist, so yes, I wanted a biopsy. I wanted to see what it was. And I really wasn't that worried because I felt like I was so low risk. And so the next day, I went to work and I told my colleague, you're going to see my biopsy. I actually carried my biopsy to the lab myself. And it sort of felt like this surreal experiment, pretending to be a patient and what's it like to go through this. And the next day, it took a long time for my colleague to come knocking on my door. And, pathologists don't usually deliver bad news to patients. And two of my colleagues came in and they had tears in their eyes. And I knew instantly what the diagnosis was, and knew that it was bad because it was quite large, and it ended up being a locally advanced, aggressive form of breast cancer. And I knew, at that moment I was going to get chemotherapy and radiation and surgery and, go through menopause and bounce back, and, that it was going to be a long process. And that terrified me. And part of, I think, what has changed some of my practice is knowing that fear, the fear of anticipation and not knowing what's going to happen to you. I knew my survival statistics, and the benefit that a physician can give you in terms of when they give you your statistics, also offering, hope in the face of reality. I remember my surgeon said, I know you've probably looked yourself up on the online calculator and saw your statistics aren't fabulous, but those are based on old studies. So, we have new treatments now. And so, I felt like I was in really good hands. I stayed here at the U. I really liked knowing, everybody involved in my care. And it brought our whole team and all our residents in training together, I think, because we all realized, this can actually happen to anybody. And, the importance of making an accurate diagnosis and a fast one can really alleviate anxiety. So that's probably how it's changed my patient care, since I don't directly
I asked
deal with
Dr.
patients.
Fleet if he had any recollections of a best or most memorable experience of his care. And I heard you maybe saying that it was the changing perspective of your whole team of pathologists that may have been one of the good outcomes of having this.
Yeah, it really did. I was new as the director of this breast service, and it really brought the whole team together because we all unified around me getting through the process as well. And it really felt like a crash course in what the patient goes through. So everything, all the details in my reports now, I know exactly what that patient's going to go through. And so I think carefully about every detail I'm including. And, yeah.
Well, the next speaker in the end, my direct boss, Dr. Pellegrini, I know will be able to answer the questions that's all burning on your mind is, you had to have had a terrible experience. What was it? I know you're waiting for what was any bad medical care outcome. Dr. Pellegrini, anything?
Bad medical care outcome.
Yeah. Any bad experience you remember?
I had two experiences, and you mentioned them both. One was abdominal sepsis and required a prolonged hospitalization, and a situation that was lingering at the time. And then the other one was the bladder cancer at a different point in life. The real bad experience that I had was with the first one, actually. The least concern, because we think of sepsis as something that you can almost always get around. And that one was only because of me and because I was a physician and because I was stupid. I ended up having an appendicitis, and I made my life treating patients with appendicitis, much like him. But I got up in the morning and I felt the symptoms, and I just disregarded that and called my friend and partner and told them that I had a viral infection and I wasn't feeling very well. And I postponed that, and it's a long story, but I ended up seeing 3 physicians in 3 corridors and discussing my problem, much like you did with that stupid x-ray of yours, without name, without... And so my advice to you, if you ever become a patient, and the one thing that particular part of my disease taught me is, and I have certainly practiced like that ever since it happened to me, I will not give advice in the corridor. I will not see you unless you want to be my patient, and if you want to be my patient, you come to my office. I take a good history, I write it down, I go through the procedures, I put the time, I fill up the request, because I learned that every one of my friends made the horrible mistake of assuming that nothing was happening to me. And it was not until I actually passed out in the operating room and was found to be septic and had to spend some 40 days in the hospital, 20 of them in the ICU, for a perforated appendicitis. I could have been treated the first day that it was diagnosed. So that, I would say, from then on, and the only person who made the diagnosis, believe it or not, 3 surgeons saw me. And he was a clinician, a medical guy who was a good friend of mine, who was a gastroenterologist, who told me, come to my office. And then I told him my little history, and then he says, now you're going to take your clothes off and put this gown. And I said, Jim, come on, you're not going to do a rectal. Yes, I am. You know, and if you don't want me to treat you, you leave. And you know, that was a defining moment in how I treat patients. Best time in my life is that, or perhaps accompanied by a lesson, was after my bladder cancer. I had a friend of mine at the time I was diagnosed who had metastasis from a bladder cancer. So I had followed, you know, the chemos and the things that can happen and this and that. And so I being relatively compulsive, I drew my lines and I said, this is my survival time, this is what I need to do, this is what I need to do with my finances, with my work, with my writings, with this, with that. And I sort of planned, if I was lucky, to live a certain period of time. And that was at the time 5 years, and then I exceeded that by twice that amount. And I realized how happy I was with that. But I realized that every one of the people that I have met with cancer since then, and including me, is totally different. Look at this lady. She got her slides and was holding onto the slides. I would be scared, being a surgeon, okay? I would be scared to be holding the slides of my disease. I have gone to my doctor, maybe he's somewhere around here, or they are some here because it's more than one, and I have said, you know, don't give me statistics. Don't give me this. I know about the disease. I know I don't want to know anything else. I want you to treat me, and I want you to provide me options in terms of quality, because quality of life to me is important. But I realized that is just me. You know, I mean, everybody feels differently. Ben was a lot more perhaps involved and thoughtful. Do I get this? Do I get that? Do I get... In my case, it was, do I sacrifice part of my quality of life to get a better operation or a more oncologic operation, or do I play my chances to preserve my bladder? And my choice was, at that time, at this age and being who I am, I take my risk. And I will get the lesser amount rather than the bigger amount. But I recognize that other patients would feel totally different. And I might have felt different if my sons would have been smaller, younger, or whatever. You know, my sons were grown up and didn't need me at the time of my diagnosis, so I figured I can do what I think is best.
I think Dr. Pellegrini related a finding that I would echo as well, which is, while the audience might think that we have a different perspective because we're physicians and we're working here, being treated special because you're in that position is a bad idea. It's a bad idea to be treated special. My story is I needed a central line put in to harvest stem cells from my blood so I could have a bone marrow transplant if I needed one. And I'll put in this line. It's a pretty big line, and it can be pretty painful, so you have to anesthetize the area. Well, surgery residents are the world's best people at doing this. But was I going to have a surgery resident doing? No, I had to have some attending in vascular surgery do it, who hasn't put one in 20 years. But he's the boss and the attending. So as he numbed up my chest to do this, he dropped the first catheter on the floor. He was going to invoke the 5-second rule, but I vetoed that. So there was that part. And then he was so nervous that he gave me so much anesthesia that he paralyzed my vocal cords with the amount of anesthetic that he gave me. And so for like 6 hours, neck was swollen. It was corset. So really, you might think that, but I think all of us would agree that being treated special is a bad idea. You want to go with the flow. I mean, it may seem kind of difficult, but you do sort of want to go with the flow on this.
Everybody should be treated special.
That's right. I have...
Everybody's different and everybody has different values, and I think that the ideal physician, if we could get one, is the one that communicates, but in a way draws the patient into the discussion. That is not easy. I try to do it as a physician. God, I know exactly what it is like to be discussing the kind of chemo, the kind of operation you're going to have, and so forth. But I try to figure out, what does this woman or what does this man want? What would make this person feel more comfortable with the way we're going to go on the treatment? And everybody feels different. I think that what Tony was saying, I see it every day. You know, you hear what you want to hear, and sometimes you're so fearful that you're totally paralyzed, and you can't make any sense of what you're telling. So I try to tell very little and to try to figure out if what you're seeking is trust, friendship, compassion, and empathy, and you want a director for your care, I'll be happy to try to be on your shoes and do it for you. If you want to direct me on your care, I'll be happy to listen to what you have to say. And it has to be that interchange that I think sometimes doesn't happen.
We only have about 10 minutes, so I welcome questions from the audience. The mics are on the middle of the aisles if you walk down, and I'll try to repeat the question if I can. Please. Thank you.
Thank you. Is there any venue for addressing a situation where your doctor is just not communicating with you? I mean, it's not something that I would think the State Medical Quality Commission would be appropriate for, because it's not really, you know, they're not diagnosing or misdiagnosing you. They're not communicating with you. Either they're not listening to you, or they're talking to you as if you don't know anything. How do you address something like that, and who do you address it with? Thank you.
So if you have a physician, I mean, the easy answer to the question, if I can repeat it, might be if you're faced with a physician, your physician, that you just feel isn't communicating well with you, just not doing a good job of talking to you, they're not listening, they're not communicating, how do you give that feedback? Now, the easy answer might be, we'll get a new physician. That might be one answer to it. But that doesn't solve the problem, does it? You're still left with a physician who does a bad job of communicating. All right, turn to the panel. Any suggestions?
Well, there are vehicles in the hospital. You can go to risk management. You can talk to the nurses. You can get your opinion on the table. Patients are reluctant to do it because it's a very defensive sort of, not subordinate, but you're not calling the shots. But it's the doctor's job to not so much tell them what they want, but to figure out very early on, how do I talk to this patient? How do I get inside? How do I gain trust? Excuse me. I'll call you in a minute. My daughter took a very dim view of my ability to answer the phone, so she put this little thing on it.
Yeah, you probably didn't hear it, but his ringtone was, "Dad, pick up the phone." That was the ringtone. "Dad, pick up the phone. Dad, pick up the phone. Dad, pick up the phone."
So the first step is, you know, if the doctor goes in with, how do I talk to this patient? How do I get their trust? How do I get inside? You're not going to have these problems. Now, the patients, they want you inside. They want you to get in there and fix things. They immediately trust you. And if you betray that trust or screw it up, then there's a lot of damage, and much of it is hard to undo. And regularly getting another doc's probably the way to do it.
You know, in a communication, there are two parties, and if you're not communicating, it could be that you are not allowing the doctor to communicate, you're not listening to what the doctor is saying, or it could be the doctor's not telling you things on the right way. In either case, to me, for the gentleman who was asking the question, I would say the easiest thing, the one that helps me as a doctor the most, is when a patient stops me and says, you know, or a family member, can you start again? I don't understand what you're talking about. Sometimes it just happens that, you know, we're both human beings on that communication, and we both have defects. So give them another chance. And if you can't understand them, then as easy as you pointed out, I won't go to the Medical Quality Assurance Commission. I just get myself another doc.
There is, I would say this, we'll get this question next. There is, every clinic every hospital, every medical facility has a medical director, a person whose job is to oversee the medical staff. You might not even know that person's name. You just write a note, the medical director of wherever it is you're going, and that would be a way of direct communication to that person. And they take a report like that very seriously. Yes, ma'am.
I don't know if it's so much a question as just with everything you shared tonight, and since I'm a person who went to school here, is this part of the curriculum now? Because I think everything that you're sharing is really valuable to become something that all physicians are aware of, and take that also as a way to weed themselves out when they're pre-med students, to realize they're not really called to this field.
So the question, I think, is the
it
curriculum in
becoming
medical
part-
school have a communications component?
Well, you've pointed out that several of the gentlemen up there are the boss of the boss, and so you guys all have the power to make sure that becomes part of our medical school training, correct?
Yes. Hugh, you want to address this?
We do. We have a whole section, we have a colleges system where every student has a mentor, and we have a committee in that colleges system that is the communications committee, as well as another one on professionalism. And so we take this very seriously. Dr. Jerkovich and other people and Dr. Bach regularly talk to the students. We have a section on how to give bad news, which we as trauma surgeons have to do a lot, oncologists have to do a lot. So we take it very seriously, and we do have it part of our curriculum now. When I was a student, we maybe had a couple of sessions, but now it's a major part of their education.
And is it part of the other schools, those other small schools around the country?
Like Harvard, that breaking the school into smaller units to make it more personalized actually started at Harvard about 20 years ago with their new Pathways program. So it really has been as a result of the public's hue and cry that, come on, you have to do a better job at this. So we do take it personally, and it is actually, the people that go around and say, can you still be a medical student? They come by every 5 years to put the stamp of approval on your head. They actually require those kind of things now.
One of the, we'll get to this question next, but I think one of the most thoughtful gifts to the University of Washington from a grateful patient was an endowment, a $1.5 million endowment, from someone who had a terrible experience as a patient because of poor doctor's bedside manner, and gave the money, this is a true bleeding purple and gold individual to do this, gave a gift to have the University of Washington have a special symposium course, education component on how to have better bedside manner, how to communicate more effectively. So that's really an outstanding, I think, a contribution to the school. So I close with just thought from the panelists, if they have anything to add to it. I think all of us, I know myself for sure, feel that you certainly are a much better physician when you've been a patient at some way along the line. And while we train our physicians young, and they may not have any diseases themselves for a while, there's no question that there's a maturity that comes from either a personal illness yourself or some very close person in your family that you've had it with. And that maturation physician does take some time for the art to meet up with the science of medicine. Pat, any last words?
No. Try not to get sick.
With that, we'll conclude. Thank you.